problem solvers, to another edition of RLR Friday. And I see Hannes is back for another edition. What a case he presented last week. We reflected about that case for hours. And we are joined by the one and only Ravi. How are you?
Would you say Ravi or Rabi? I can't tell because there's only one of each, honestly. But Ravi, a pleasure to see you. I don't know if he met me or you, but I think you should say hi too. I'm doing very, very well. I just inhaled my post-exercise breakfast and I'm gliding. Ravi, how are you?
I'm doing very well. How are you?
Brief and concise as always, my friend. We adore you for that. Reza, who do we have here?
So we are very excited today to have a case presenter from my alma mater, Manuel. Manuel, if you don't mind unmuting yourself, just tell us a little bit about your background. What do you do? What are your interests? And maybe something that you like doing outside of the hospital.
Oh, absolutely. So I guess I'll give you the one-liner. So I'm a 35-year-old male. I am a hospitalist and instructor in medicine at the Johns Hopkins Hospital. And I've been practicing here since August of 2022. Prior to that, I was at Brigham and Women's Hospital, also at the instructor level. And I did my training at Indiana University School of Medicine, graduated in 2016, followed by a residency in internal medicine at Inova Fairfax Medical Campus in Virginia. So my interests outside of medicine include playing the piano. So I'm a big jazz piano aficionado. And occasionally I do some gigging. And in addition to that, I am also very much interested in physical fitness, particularly powerlifting, hiking, and biking as well. The latest hobby that I've picked up right now as part of my interest in travel is learning languages again. So in high school, I learned Spanish. And then my family's from the Philippines, so I'm trying to learn a native language, but the latest one that I've gotten into is Korean.
Wow, you are quite the individual, and I love all your interests outside of medicine. Ravi, il fait du piano.
What?
Is the what because I have the Invisalign in, or is the what?
Oh, I know. He makes two pianos?
Oh, so actually, the better way to say it is il fait joue du piano.
He plays piano.
No, sorry. Il joue du piano.
He plays piano. Nice.
Yeah.
Amazing. I thought, oh, you meant, okay, never mind. You know, the words DU and DEUX sound very similar.
I haven't got to DUX yet. So I only know
I think
one.
that's very ironic, DXRX EDU, that you haven't incorporated the X in your DU, but yeah. We are very savvy and very skilled in medicine, maybe, and the rest is demonstrably zero. But I can't believe you speak this many languages. It's very, very cool. Prof Rez?
Well, I'm practicing. That's don't be too impressed.
I know.
Okay, it seems like we're ready for the case. Manuel, whenever you're ready, please start presenting. Just be mindful of the person scribing to make sure they're caught up with what you're presenting, and then Ravi will tackle the first aliquot premiere.
All right, here we go. So this is a case from when I was a resident, particularly PGY 2 year, that I thought was particularly interesting. So our chief complaint is fever, arthralgias, and a dry cough. So we have a 22-year-old previously healthy male who was brought to a rheumatology clinic by his parents in October of 2017 for intermittent fever with arthralgias and a dry cough. Okay. In September of 2017, he went to Korea to work for a biotech company. And at that time, he had bilateral wrist and elbow pain with worsening swelling in his first week there. with an associated rash in those areas. He found no relief with over-the-counter NSAIDs or Tylenol. Upon his evaluation by local doctors there, he had an elevated ESR and CRP. Unfortunately, we don't have those values, but negative rheumatoid factor, anti-CCP, and ANA. He was told he may have had reactive arthritis. So then a few days prior to presentation to a rheumatology clinic in the United States, he noted pain and swelling in both ankles and feet that he stated as achy, constant, rated 6 out of 10, and relieved with ibuprofen. So I'm just going to open the floor after this first aliquot.
Thank you, Manuel. It's a very intriguing story. I gotta say, I think that I think we're at the stage where, sorry for the background noise. We're at the stage where I think we're still trying to clarify what the problem is. And the features that I think we can try to incorporate are features of systemic inflammation, which is the fever makes an unequivocal argument for that. Maybe absent just proving it on exam, but the ESR and CRP have us completely locked into that. Here, let me close the window real quick. Trying to get some fresh air, but clearly work's being done outside. But yeah, I think that the fever plus the ESR or CRP puts any doubt into the inflammation hypothesis, because the fever may be subjective. And so the real question is, well, what is the time course of this inflammation? And it's definitely subacute. And the localizing features are that this patient seems to have a joint syndrome. And I think seems to is important because we heard that the joints hurt initially, but then I think it seems like people examining this patient were convinced that there's actually inflammation in the joint with the swollen and boggy nature of said joints. So I think it's clear that the problem that we're trying to solve is a subacute inflammatory arthropathy, and you might commit to saying arthritis, or you might hold back to say arthritis until you demonstrate confident proof of an arthritis. And then if you are confident that it is arthritis, you can start to apply the labels of polyarthritis or asymmetric oligoarthritis, depending on the distribution you see. And as is true for any inflammation in any category, you have to first think through the infectious causes, and then after that, pick which one of the MADE you want to follow up next. And in the world of arthritis, the immediate selection is usually very evident. So think about autoimmune diseases. The one major caveat to that is a kind of autoimmune disease, which is a crystalline disease. And that deserves consideration only if patients have prominent risk factors for them at this age, including alcohol intake, kidney disease, so on and so forth. So to summarize, there's fever, there's joint stuff. The fever is, along with the ESR CRP, is confirmatory of inflammation. The joint stuff, you could read this and be convinced there's an arthritis. You could read this and be a little conservative and say, hold on, I don't want to commit to that yet. And then there's the skin stuff. Which again is a little bit too loose to latch onto now, but those are the features I think we're going to try to explain in this young, presumably otherwise healthy man. And that's all I can say with any degree of confidence. Prof. Raz, any thoughts to layer on?
I love that initial approach. And I think the way you make progress in the DDX of like inflammatory arthropathies is what the skin exam will show. So this patient's skin exam may be a prominent clue to the final diagnosis. And I say that because headache, arthritis, abdominal pain, these are often bystanders in disease presentations, but skin stuff is usually not a bystander and can really help point to the actual diagnosis. And then the last thing I'll mention is just his travel history. Like, I wouldn't latch on to the fact that he was in Korea to help frame the DDX, but that's something I would incorporate in that ultimate DDX as 2 frames, like one from his travel destination and one without. But right now, I'm not inclined to incorporate that into my problem representation. but more from you, Manuel.
Certainly. I'd like to provide a bit of a review of systems. So in addition to the symptoms that were presented during the HPI, he did endorse a sore throat. And then clarifying his musculoskeletal symptoms, he also endorsed morning stiffness as well as muscle weakness. But apart from that, he had no chills, night sweats, or unintentional weight loss. No other upper respiratory symptoms, no other cardiopulmonary or GI symptoms. No GO symptoms, including dysuria, hematuria, genital rash, or ulcer. And then he had no easy bruising, erythema, hives, photosensitivity, no skin tightness, no Raynaud's phenomena, no neurologic or psychiatric symptoms associated. And so I'm just going to pause there for additional comments that might alter the differential.
Yeah, this is really helpful. And I love that you provided information on the morning stiffness, because if you're trying to tease out inflammatory arthropathies from non-inflammatory arthropathies, this is a huge clue that this is an inflammatory arthropathy, in addition to the patient's fever and elevated ESR and CRP, because non-inflammatory, like osteoarthritis, it actually worsens throughout the day. It's ouch with activity, but the inflammatory ones in general get better throughout the day. And so this prompts my mind to think about stuff like spondyloarthropathies that can certainly have articular manifestations in addition to other processes. And then the sore throat, you should incorporate that into your framing of this case and try to link sore throat to joint pain. And it's not just one possibility, but you can easily imagine someone can have a strep throat and then subsequent to that, develop acute rheumatic fever, for example. But there's many ways where you can link sore throat to joints that has a long DDX. So it doesn't really narrow it completely, but this would just prompt me to take a good look into the oropharynx. Yeah, and I'll leave it at that and see if Robbie has anything else to add.
Rafraz, I think that's such a wise thing to do to maintain some pause, because as we try to replicate the goal of really reflecting on what we'd be thinking in real life in this patient, I would honestly be cognizant of the trap of overemphasis on so much subtlety. The skin rash is subtle, the dry cough is subtle, the arthritis may be subtle, the fever may be subtle. And I think solving the wrong problem can beget a lot of consequences. So I'm standing right there with you, with my knees locked, like I'm ready to run, I'm ready. But I don't think the go button has been hit yet. There's too many things that could lead us astray. So you're waiting for the appropriate topography of the syndrome to emerge and not be drawn into something that turns out to be an innocent, unrelated, mild issue.
And really, Robbie, you captured it best in that first alcohol where you're like, I know there's inflammation and I know there's joint stuff. And then the rest is just to see what it is. But I think that was brilliant.
Yeah. Yeah. I'm curious. I'm going to try very deliberately to outline the moment that I think we can start running. I'd be curious to observe what that turns out to be.
I'll be running right behind you, my friend. So please let me know when you identify.
Oh, Papraz, I'm only going to be seeing the back of your bald head on this. All right, Manuel, tell us some more, please.
Absolutely. So I'll provide you with his additional history. So he has no past medical history. No history of low back stiffness, uveitis, plantar fasciitis, sexually transmitted infections, IBD, or gout. In addition to that, he does not take any medications. He has no known drug allergies, no past surgeries. In terms of his social history, he graduated from MIT with a degree in biotechnology. He was recently accepted to medical school in New York City, and he was using his gap year for work and travel. Not sexually active within the last 2 months. His alcohol use was just limited to social occasions. He has no illicit drug use, and he's never smoked tobacco products. His family history is notable for Sjogren's syndrome in his father. Any thoughts?
Yeah, I think the data that we're getting here is really reassuring, really reinforcing the probably default assumption we're making, is that if this subacute syndrome is so prominent and has been allowed physiologically to continue for so long, that the substrate that it is occurring in is probably baseline healthy. And I think you would imagine that if the patient's predisposing conditions were more prominent, that the tolerance for this to occur and to travel to Korea and whatnot may not have been there. So it's interesting that I think many of us might have made the assumption that he is otherwise healthy and has maybe some mild risk factors for other things. So that, I think, prediction pans out in this case. I would be very surprised, like Hannes did last time, where we had a case of episodic syncope, and then boom, the past medical history was surprising to me in that it was full of really concerning information that turned out to be very profoundly helpful. Here, I think the default assumption that a subacute syndrome that appears to be mild for now is occurring in a host that is otherwise healthy pans out. That's my kind of take on this information. Maybe some of it will be helpful in the future. Prof. Rez, thoughts?
I love that take, and I'm just yeah, and it just hit me like you just using the term subacute is so helpful here, because oftentimes when we're seeing fever, we're like, where is the infection? But not this time. I mean, you could have atypical infection, but this time we're like really considering autoimmune, maybe in that number 1 slot, and then atypical infection number 2 with malignancy.
And I'd like to interject here along the past history. So he is immunocompetent, and also he has received all of his age-appropriate vaccinations.
Manuel, we love interjection, so please keep those coming. It's one of our favorite words is interject. Robbie hears it far too often from me.
All right, so shall we move on to the physical exam?
Please.
All right. So this is his initial physical exam. So his temp is 99.2 degrees Fahrenheit. His heart rate is 80. Blood pressure 110/65. Respiration 16. His BMI is 25.1, and his oxygen saturation is 99% on room air. In general, he's in no apparent distress. He appears to be a young athletic male, alert and oriented ×3. On HEENT exam, normocephalic, atraumatic in terms of his head appearance, normal ears, no oral ulcers, no cervical lymphadenopathy, and he had no oropharyngeal lesions. His cardiovascular exam revealed a regular rate and rhythm with normal S1, S2, no murmurs, rubs, or gallops. His lungs were clear to auscultation bilaterally. His abdomen was soft, non-tender, non-distended, normal active bowel sounds, and I did not appreciate any hepatosplenomegaly at the time. He had no neuromuscular weakness on neurologic exam. On MSK exam, we did a full joint exam. So I'll give you what's positive first. So on wrist exam, no swelling was appreciated on inspection, but he did have painful flexion and extension in both wrists. And then on foot exam, he had swelling and slight redness in the 5th MTP joints, and he was tender to palpation in the right, 2nd, and 3rd DIPs and PIPs. Elsewhere, he had no visible deformity, no tenderness palpation, and no limitations in terms of active or passive range of motion in all other joints inspected. All right, and now I'll give out the skin exam. And so for that, I'm just gonna share my screen.
Manuel, you should be able to share it because we made you a co-host.
Okay. Okay. Just going to pause one moment to also allow our diligent scribe to catch up. Okay. Well, unfortunately, I'm experiencing just some technical difficulties here, but I'll just verbally describe the rash. All right, so it is what I would call a salmon-colored macular rash that I noted most prominently over his chest and just below the neck. And so I'm going to pause here and welcome thoughts.
One question I had, Manuel, I would, so can you, at the bottom of the screen with the share button, when you click on it, it's not allowing you to pick I would love to see this rash.
Sure, I'll work on that during the discussion.
Okay, perfect. So maybe the way to tackle this, Robbie, we can just dance a little bit together. And I think, and maybe we can start with the MSK and then incorporate the skin and then the background data and see like what progress we can make. I think with the joint, like, initially when we were sharing our thinking, we were like, this patient has arthropathy, but we didn't specify arthritis versus arthralgia. And the way I think of it is arthralgia is more broad of a term. It's like vasculopathy versus actual vasculitis, right? And so I was just curious from your perspective, because you raised that, and of course, the number of joints involved, the location of which joints are involved are important, but maybe we can just start about like, does this confirm for you the itis of arthritis, and how do you tell?
Yeah, honestly, there have been many times in real life where I wouldn't be able to tell. The most this distinction is most obvious when you feel a joint like of osteoarthritis and it hurts the patient a lot, but there's no swelling. And so here, you definitely want to. This is why there's a lot of debate, and this is why rheumatologists love to examine and do their own exam, because everyone has their own barometer about how boggy and swollen a joint is. And just think about right now after running, my knee hurts, but it's definitely an arthralgia because there's no swelling whatsoever. But if you look at him, you see the word swelling, I think, pushes you into the world of arthritis. So I have to say, in real life, it's tough, and this is the rheumatologist's neuro exam equivalent. When we do a neuro exam versus a neurologist, I think this also applies to the joint exam. So I'm much more confident now calling this an arthritis. What about you?
I'm right there with you, and I love that point because, like, I feel like when you have data like swelling and erythema, it's so easy to jump to that conclusion, meaning it's very suggestive. But when you don't have it, it's hard to exclude arthritis, right? It's almost like that patient who complains of weakness, but you can't detect it on exam. You can't really rule out true weakness. Sometimes it's detected on that EMG nerve conduction study. So I'm right there with you. I would say this is a polyarthritis of both small and large joints, and it seems to be symmetric to some extent. With both wrists involved, you have a couple of the joints of the hands and the joints of the feet involved. So large and small. And so then I think it brings us to this rash. And I want to say something. It's really, I know everyone's commenting on the buzzword salmon, but how many times have you seen someone with fever sort of have redness? And that's like through vasodilation. And so you have to be very cautious with anchoring too much on the word salmon colored rash. But here, I guess, like looking at this rash, it you definitely have erythema, and I would be curious of like whether it blanches or not. Whenever I see erythema, it looks like this one will blanch in certain spots. It almost looks like it's a little papular too, but definitely prominently on that chest and neck. And so I think we can confidently now say that we have a subacute polyarthritis with a erythematous, probably blanching rash on the chest and neck that seems to have areas of papules as well, but is not purulent. And so now I'm activating sort of like the joint and skin differential diagnosis for subacute processes. And I was hoping I can throw it to you, Robbie, to make more progress on that. And then I think we can start thinking about the other subtle stuff, like does the throat issue help us here? You know, he's complaining of some sore throat. Does that help us, et cetera? Although, you know, yeah. So.
Yeah, no, Professor, I think I think now we can start to definitely build some momentum. And I think the intriguing part is even focusing on the nature of the arthritis. And the most helpful thing I think for me is the involvement of the DIP joint. The DIP joint is very unusual in the seropositive arthritides, which include lupus, Sjogren's, and rheumatoid arthritis. So if you're not convinced that this is an unusual case based on the presentation of the rash, whenever you see the distal part of the body, the DIP, be it in the foot or the hand swollen, you should really immediately lock that in as an unusual form of arthritis. And the unusual forms of arthritides are probably best encapsulated by the all-encompassing category of the seronegative spondyloarthropathies, the SPAs, of which there are many. The primary spondyloarthropathies are ankylosing spondylitis, reactive arthritis, IBD-related arthritis, and psoriatic arthritis. And 3 of those 4, all except ankylosing spondylitis, come with a prominent rash. Then after you move from the spondyloarthropathies, there's a few other diagnoses that are seronegative arthritic syndromes. With Prof. Rez already mentioned rheumatic fever, Still's disease, palindromic rheumatism, and the list gets more and more and more esoteric. So I think for now, I think it's very easy to use the morning report context and the word salmon and the concomitant pharyngitis to prioritize Still's disease. But I think that would negate base rate. And I think base rate would tell you to prioritize a seronegative spondyloarthropathy with an unusual rash, like psoriasis with inverse psoriasis potentially. But I think the labs would be telling, because what singles out the seronegative spondyloarthropathies is they're minimally inflammatory on labs. There should be no white count. There should be no anemia. They're usually very kind of mild. If we see a robust inflammation signature on the labs in the form of leukocytosis or thrombocytosis, then I think we probably have enough momentum to negate the base rate of disease. So that's how I'd be thinking about it. You, Prof. Rez?
I am right there with you. And I think like looking at that rash in the joints, it would make me think of adult onset Still's disease, but I'd be reminded that that really is a diagnosis of exclusion using Yamaguchi's criteria. And you have to do such a great job of ruling out other etiologies before you say, oh, I need to give this patient steroids. But the interesting thing with Still's is it can definitely manifest with a sore throat. So far things are consistent for this very rare diagnosis, but being humble and mindful that it is very rare, it is a diagnosis of exclusion, and there are Yamaguchi's criteria for Still's disease.
Okay, so moving on with the initial workup. His CBC with manual differential was notable for a hemoglobin of 13, which is just below the lower limit of normal on our assay, with a low normal MCV. All other cell lines are within normal limits. His CMP was also within normal limits. On UA, he had no evidence of hematuria, proteinuria, or infection. Anti-streptolysin O, ANCA, Lyme antibodies, Parvo B19 antibodies were all negative. although with a parvo B19, his IgG was positive. Uric acid was within normal limits. His ESR and CRP were both high. ESR was 79 and CRP was 97.6. Rheumatoid factor was negative, as was the CCP. And a comprehensive ANA panel was performed, which was all negative. So that included the ANA screen, anti-double-stranded DNA, SSA, SSB, Smith, RNP, and SCL70. His HLA-B27 antigen was negative. Iron study showed a low iron of 20, low TIBC of 208, iron saturation low at 10, and a high ferritin at 1859. His chest X-ray, PA and lateral, showed no acute intrathoracic process. And then he had a POCUS exam of the affected joints. So the left wrist showed increased erosion, but no effusion. And then the right foot showed an effusion in the second, third, and fifth MTP joints, and a slight effusion in the right second, PIP, and DIP. His right ankle showed no evidence of active synovitis. And I'll pause here.
Ooh, this is so intriguing. I think I'm going to take a second just to summarize what we have. We have a patient with otherwise healthy, who was a subacute syndrome, now confirmed to be an arthritis syndrome, with a interesting macular rash over the chest, who has on borderline microcytic anemia, but I'll refine that to say findings concerning for iron deficiency anemia with the low percent saturation countered by a very high ferritin, who otherwise has a seronegative pattern, namely the ANA is negative and the rheumatoid factor is negative. And I think I'll just kind of free talk, Prof. Rez, and then pass the mic to you. I think if we anchor ourselves first in making sure that we consider at least infection hypotheses, this would not be incompatible with tenosynovitis, dermatitis from disseminated gonococcal infection. I think that would be something to think about, as would blood cultures be for the possibility that the iron deficiency anemia represents a GI disease process, and there's been translocation of things like Helicobacter or Campylobacter or Salmonella. Those are things you'd never want to miss. So I think blood cultures and urine GC would be something I think about in the infection category. But as Prof. Rez said, I think autoimmune is capitalized in this situation for reasons we've already mentioned. And so I think that the minimally inflammatory signature is a further evidence to suggest that there might be a spondyloarthropathy. And here, the high ferritin is very much incompatible in line with the hypothesis of adult onset Still's disease. However, the low percent iron sat is a counter to that, as is the lack of leukocytosis, thrombocytosis, or a liver enzyme elevation. So I think with the iron deficiency, with a possible iron deficiency, the possibility of occult IBD with spondyloarthropathy does jump out. And even you don't have to invoke occult IBD. Spondyloarthropathies all have occult intestinal manifestations that may be causing some bleeding. The only seropositive set of diseases that can show up with a rash and arthritis are the amyopathic myopathies. So there are amyopathic versions of dermatomyositis that show up with an arthritis, a rash. Those I think would probably deserve consideration. And after all that washes away, you have to apply the rule of thumb that if a disease looks and smells autoimmune but isn't quite fitting, you have to think, is it a drug-induced or a cancer-induced autoimmune hypothesis? And those would be at the bottom tier of thinking only after these hypotheses are queried more closely. Prof. Rez, thoughts?
I'm right there with you, and I'm trying to challenge myself as to what would I do next to test the various hypotheses. And I really think leading the DDX is probably a spondyloarthropathy or adult onset Still's disease. I think these two are leading it because you're getting clues of GI manifestations with a low iron SAT. Then you have these cutaneous manifestations, the DIP joints are involved. So there's clues for the spondyloarthropathies, specifically, as you mentioned, Robbie, inflammatory bowel disease. And yeah, I think this can be a bit challenging. Like, are you dealing with adult onset Still's disease? And this is where it would be helpful to have someone that has an experience with actually treating and managing adult onset Still's disease. So at this juncture is when I would involve a rheumatologist, because I think it is that. I think it is adult onset Still's disease based on the pharyngitis, the macular salmon colored rash, and the high ferritin. But the reason I pause is the lack of leukocytosis that you would expect with adult onset Still's disease. The fact that the DIP joints were involved, though maybe that is a manifestation of adult onset Still's disease. So in any case, all that's to say, I would be really curious whether the treatment threshold has been surpassed for a rheumatologist to start, prednisone, and then see how the patient responds to that. And these patients with Still's often, I'm looking at the Yamaguchi's criteria right here. There's 4 major criteria. One is these high fevers, which this patient has, arthritis for more than 2 weeks, the rash on the chest. What this patient doesn't have is a leukocytosis of one of the major criteria. And then the minor criteria are sore throat, lymphadenopathy, hepatosplenomegaly, and abnormal liver chemistry tests. So yeah, Manuel, we're ready for you to reveal more data and teach us.
Sure, this case does evolve, but just some important data to report is that he did have blood cultures ×2, which were ultimately negative, and he did have a gonorrhea and chlamydia panel, which were negative. All right, so on follow-up, he did endorse ongoing pain in the right elbow, shoulder, and right wrist. And then his erythematous rash now involves both hands and shin, similar to that which was seen at the initial visit. On further questioning, he did state that his max temperature was 101 at home and then 100.5 in clinic. He had right elbow and wrist swelling on exam. His ESR and CRP were still elevated, and so he did receive essentially intramuscular corticosteroids in the right shoulder ×1. He was started on prednisone with vitamin D supplementation. A few weeks later, he did report that he had daily fevers for the past 5 days in the past week. And at this point, it's November 2017. But no skin rash, but still has a dry cough. He had repeat diagnostic workup, which was notable for thrombocytopenia to 90,000. And his ferritin was above our assay at greater than 35,000. His acute hepatitis panel was negative, HIV was negative. And so he was admitted to our hospital for his extremely elevated ferritin. Additional workup was notable on the differential for the CBC that he had a bandemia that was PMN predominant at 74%. with a lymphopenia at 0.32. Fibrinogen was normal. AST and ALT were both elevated. So AST was 158, ALT was 173. And then he received 1 liter of IV normal saline, but at the time he refused pulse dose steroids. And just to fast forward a little bit regarding his hospital course, his further workup revealed an elevated LDH at 737. During his hospital course, hematology was also consulted, who recommended a bone marrow biopsy, and I can show a representative image. All right, but I will pause for discussion.
I'll let Robbie interpret the representative image of the bone marrow biopsy. But Manuel, this is extremely helpful. So I think the initial frame, can I just ask you one quick question with regard to the rash? Was it blanching or non-blanching?
This rash was blanching.
It was blanching. Okay, perfect. I think the initial frame was that we were dealing with some form of rheumatologic process, specifically adult onset cells. This patient was given prednisone. And as we mentioned in the previous aliquot, you want to assess the response to treatment. So your treatments for these rare conditions, be it sarcoidosis, be it adult onset Still's disease, is a form of diagnostic test. It's a diagnostic maneuver. This patient worsened despite having prednisone. So to me, this lessens the likelihood of a run-of-the-mill autoimmune process. And now the thrombocytopenia lessens the likelihood of our initial hypothesis of adult onset Still's disease. So we have two reasons to question that: the lack of response to prednisone and the new thrombocytopenia. And I think this is really, really critical, this juncture of the case. And I'm sort of happy that the patient refused systemic steroids, because I don't think I would have recommended it at this juncture, because I've given the guy steroid, he didn't get better. So I don't think I would pulse dose this patient with methylprednisolone. The ferritin, I think, can be a clue. So, like, yes, every inflammatory condition can cause high ferritins, every inflammatory, but this is so high that you have to at least consider a few possibilities. One includes primary iron overload being hemochromatosis, which certainly can cause arthritis, certainly can cause a DIP arthritis as well, specifically, but it wouldn't cause these other manifestations. And the percent SAT would be really high, higher than SAT. So you can throw that out the window. Then you think about histoplasmosis you have to consider. And histoplasmosis is interesting. We said if it was infection, it's atypical. Fungal infections can have joint manifestations. They can have cutaneous manifestations. They can involve the bone marrow. Basically, you can think of TB like you can think of histo, and histo is present everywhere. So could there be atypical histo? But then the guy didn't have any pulmonary manifestations. I'm open to that possibility, and I would have a low threshold to scan the chest to make sure that there isn't any nodules or anything that may suggest disseminated histoplasmosis. Then the other considerations, adult onset, so we already talked about that, but then the other one is HLH. So whenever you have cytopenias, especially multiple cytopenias, with this degree of hyperferritinemia, with a rash and joint involvement, you have to think about hemophagocytic lymphohistiocytosis. Now, this condition comes in two forms, primary and secondary. And despite its name being hemophagocytic lymphohistiocytosis, hemophagocytosis just essentially means that cells are being eaten up. It doesn't have to be the case. And so when we're looking at this bone marrow, where I'm going to pass the mic to Robbie to interpret, one consideration is, are there hemophagocytosis or not? But once you think of HLH, you have to think of the primary form, which often occurs in kids, or secondary. And secondary forms is usually, is it EBV? You think of the sore throat, you have to consider EBV. Did he get exposed to antibiotics and has a rash because of that? So this would prompt me to send EBV, CMV. You have to think about lymphomas as well. And the LDH was elevated here, so you have to think about lymphomas, and this patient's at risk of a serious lymphoma precipitating an HLH. But now all of a sudden, Manuel, my friend, this becomes an emergency, and you're wondering, does this patient need eculizumab or some form of chemotherapy? But I'll leave it at that and then pass the mic to Rob. I was joking about the bone marrow biopsy to interpret. We can dance together, my friend.
Yeah, no, I looked at it, but I want to stay authentic to the reasoning that you just did, which is absolutely superb. And you're teaching us that a ferritin of 35,000 certainly dominates the frame, but approaching that with the appropriate amount of caution, because you can be faked out. And I think when you have ferritin and you have cytopenias, it's hard not to use HLH as just a diagnostic framework. The patient may not have HLH, but the causes that you might work up as a result are very, very important. And it does beget the idea, did this patient have acute mononucleosis and then slowly evolved into HLH? Does this patient have an underlying malignancy that slowly evolved into HLH? Or our initial hypothesis was true, that this patient had one of the two autoimmune diseases that can evolve into HLH. The first is lupus and the second is Still's disease. And I think that the idea that he might have had Still's disease turn into HLH is possible, but a diagnosis that you can only render when you've done the infectious mononucleosis, histoplasmosis, and malignancy hypothesis. So I think that's the way I would be analyzing in real life is EBV, CMV, endemic mycoses, exposure history. In East Asia, you may have to expand your endemic mycoses testing, looking for the possibility of an underlying lymphoma. And then if all those come back negative, I think you can render the diagnosis possibly, bless you for whoever just sneezed. You can render the diagnosis of exclusion that this patient had Still's disease and evolved HLH, or a further diagnosis of exclusion is this person has primary HLH. But I think my interpretation of the bone marrow is the following. The patient presented with fever and pancytopenia prompting bone marrow examination. Bone marrow aspirate smear, right, Giemsa stain shows erythrophagocytosis. I would no way be able to interpret this bone marrow. I'm really glad that I can see the bottom of your screen, Manuel. It's very, very helpful. But with that as a prominent clue and guiding me, I think, and of course the big arrow sign, I think you can see that there are big cells that have inhaled red colored thingies in them. So it makes sense that this is in fact what I cheated and read.
Yes, I had to put that for myself because I knew that I would forget when I was presenting this during noon conference.
Believe me, I know the feeling.
So I will interject just so some more pertinent negatives for you. Of course, we checked for all of the common things, including mono. So his mono spot was negative. I'm trying to think of what else that was on our wish list that ultimately turned up negative. Yes, he was also pan-scanned. CT chest, abdomen, and pelvis did not show any nodules or lymphadenopathy. So everything that I've discussed so far is just our prominent salient workup.
Yeah, I think Prof. Rez, if we say like loosely that all the workup for infection and cancer is negative, then I think action steps might be genetic testing for primary HLH. And if that is negative, I think you can say, hey, maybe this person evolved from Still's to HLH, and that's why they didn't have the high white count or they didn't have the thrombocytosis initially. We had a grand rounds. Do you remember Sarah Goglin, Prof. Rez? So she got a case, discussed a very challenging case of Still's that evolved into HLH about a month or so ago that was a little bit more slam dunk for Still's initially. There was like nothing else, and then the patient got HLH-E. So that's how I learned of that diagnosis. But I think if everything is negative, lymphoma and infection, I would say genetic testing for primary HLH given the age of the patient. If that's negative, you might call this Still's to HLH. Thoughts before Manuel tells it?
No, I love that. I wasn't familiar that AOS, adult onset Still's, can induce HLH, but I think right now is probably like the patient needs treatment for HLH ASAP, and then going from there.
HLH genetic testing was performed, but it took a long time to come back. And ultimately, the primary genetic testing was negative.
We're holding our breaths, my friend. Tell us what you all found and what you how you put this together.
Yes, so this patient presented with adult onset Still's disease that was complicated by macrophage activating syndrome, which is what we called it. So adult onset Still's disease it's pretty rare, and I found the prevalence to be 0.47 out of 100,000 people in the US. In Japanese and European studies, the reported prevalence ranged anywhere between 1 to 34 cases per 1 million people. And there's no sex predisposition. It can occur equally in males as well as females, but the age distribution tends to be bimodal. So there's one group of people who presented between the ages of 15 and 25, and then 36 to 46, but there are case reports of presentation of adult onset Still's disease after the age of 70. The pathophysiology is actually unknown. So there's some thought that there is an exposure to a danger signal, which might be a virus or bacterial pathogen. So Yersinia and Mycoplasma have been implicated in the past. But ultimately, it leads to upregulation of an inflammasome. So upregulation in cytokine expression of IL-1, tumor necrosis alpha, and IL-6, which leads to that elevation in serum ferritin, and then also increased neutrophil activation. And what leads to the macrophage activation syndrome / HLH is the upregulation in interferon gamma. So those are all proposed targets for therapy. But regarding the clinical manifestations of adult onset Still's disease, so this patient actually had daily fevers with dramatic temperature swings within 4 hours. So oftentimes it's called quotidian or double quotidian fevers. And then the rash is the evanescent salmon-colored maculopapular or macular non-pruritic rash. Commonly, there's also arthritis, as we saw in this patient, that can involve any joints. So knees, wrists, ankles, elbows, PIP, and shoulders. And then pharyngitis and hepatosplenomegaly are common. But any other organ can be involved as well. And it can have a natural history where it's chronic, intermittent, or monophasic. So the chronic is the persistently active disease that involves mostly arthralgias and can have destructive arthritis. Intermittent involves one or more flares that's less severe than the initial presentation, with or without articular symptoms. And it remits in a few weeks to about a year. Then there's also the monophasic presentation, which presents with high fever, rash, serositis, and hepatosplenomegaly, evolving in weeks to months, but resolves in less than a year. So as Robbie and Reza had mentioned, this is a great mimicker of lots of things that I saw in the chat and in our discussion, and it's ultimately a diagnosis of exclusion. So with that, doing a thorough H&P plus a thorough workup is essential. Labs might show an elevated ESR, leukocytosis with white blood cell count greater than 10,000 with granulocyte predominance, negative ANA rheumatoid factor. And then on imaging, you will see typically normal features, but might see soft tissue swelling, plus or minus joint effusions, periarticular osteopenia, non-erosive narrowing of the MCP joints that might progress to ankylosis. And then we had also alluded to the Yamaguchi criteria. So we come to the conclusion on exclusion that we suspect adult onset Still's disease. And so with the Yamaguchi criteria, we need at least 5 of these feature, with 2 being major diagnostic criteria. So the major criteria include a fever of at least 39 degrees Celsius lasting about a week, arthralgias or arthritis lasting 2 weeks or longer, and then the characteristic non-pruritic macular / maculopapular skin rash that's usually found over the trunk or extremities during the febrile episodes, and then a leukocytosis with at least 80% granulocytes. There are some minor criteria as well. So sore throat, lymphadenopathy, hepatomegaly or splenomegaly, abnormal LFTs, particularly elevations in AST and ALT, plus elevations in LDH, and then negative ANA and rheumatoid factor. All right. So in terms of management of adult onset Still's disease, you assess for occurrence of symptoms with frequent follow-up, assess for side effects, and monitor for recurrence. You monitor the LFTs weekly for about the first 3 to 4 weeks after starting therapy. And particularly in this patient's case, you received anakinra. So just going back to the therapeutic approach, it's based upon the joints that are involved, as well as an assessment of severity by an MD global scale. So just summarizing and without going into detail regarding the particular scales, you think about mild versus moderate versus severe disease. So on initial therapy, your therapeutic options include anakinra, glucocorticoid monotherapy, and then NSAIDs. So you try one of those 3 options and then just reassess disease activity. After that, if you have no response to therapy, you ultimately will look into immunomodulator therapy, which targets various points in the proposed inflammatory pathway. So as our patient did receive glucocorticoid therapy as well as NSAIDs, but didn't respond, he ultimately did receive anakinra, which is an IL-1 immunomodulator. And then if he had disease progression, he would ultimately require other therapies such as canakinumab, tocilizumab, methotrexate. And then beyond that, you can also consider abatacept as well. And so that's where we left our case, actually.
Manuel, thank you so much for that tour de force of teaching. That was epic. And I know Yaz has been writing at 1 million words per minute, and I can't wait for Yaz to share with us and recap all the learning points. But thank you so much for presenting that case, my friend. Very educational. What a journey. And yeah, a lot to reflect on here.
My pleasure.
Definitely. Thank you so much, Dr. De La Rosa, to bring us this great case. It was definitely a journey. And I felt so engaged, and I think I learned so much, especially from rheumatology, thanks to Dr. Rez and Dr. Rabi. And the chat was amazing as well. So for teaching points, we started with an approach of a systemic inflammation, localization features, if the joint involvement was symmetric, asymmetric, poly, mono. We also look for other systems involvement, where Prof. Rez gave us this pearl of bystanders are common except for dermatological diseases or like accompanying symptoms. So we have also to consider the epidemiology to an item to our differential. Now, for inflammatory arthropathy versus non-inflammatory, inflammatory usually gets better during the day, non-inflammatory worsens. And there we added their mnemotechnic. Also, a subacute course opens the door to consider autoimmune and then atypical infections and then malignancies. Now, to define arthritis versus arthralgia, we normally think of swelling. It helps differentiate. It makes us think of arthritis. Nonetheless, we have to describe the pain, accompanying characteristics of the joint, and it can be very tricky. Now, when looking at rash, is there erythema, papular, vesicular, nodular, does it blanch or not? And the localization is also important. We look to the DIP and PIP involvement, which is unusual. So we can think of spondyloarthropathies and then other rheumatic diseases, thinking that spondyloarthropathies usually have normal WBCs and no anemia. Now, if we are suspicious of ASD, we use the Yamaguchi criteria because this disease is a diagnosis of exclusion many of the times. We need 5 of the features, being two of them major at least. Dr. Ravi in the chat gave us the mimics of Still disease, which is the myriad of mimics. also, we can't discard infections etiology with these kinds of rashes. So a blood culture could determine if there are bacteria such as Salmonella. If a disease looks autoimmune but it's not quite fitting, think drug-induced or malignancy. We also thought about amyopathic myopathies, and also thinking, well, we can assess the response to the treatment, and it could help us with the differential. So then we turn into an HLH approach, remembering that HLH is an option, and it could be primary or secondary cause, the underlying malignancies such as lymphoma, mononucleosis that evolved, or if this patient had immunity such as SLE or is still again, then it came up into our differentials. And for the last approach was AOSD. Dr. De La Rosa gave us an amazing pathophysiology approach, being tumor necrosis alpha, interleukin-1, interleukin-6 as the cause of this inflammation, and how it can be a systemic involvement, being serositis, fever, rash, and again, always telling us that this is a diagnosis of exclusion. And again, the management starts from the smallest to the biggest one, and say it's glucocorticoids. If it doesn't respond, go to the immunomodulator, and being anakinra, and then jumping into tocilizumab, methotrexate, or abatacept. And these are all of our great teaching points from a great discussion. Back to you, Dr. Ress.
Yes, that was brilliant. I just love the way you've organized your teaching points, and you covered it all. So I'm sure that the audience are going to focus on this when we put it on YouTube. Thank you so much for that epic teaching. That was well done. I wish you all a happy weekend, a safe weekend, and we'll see you again soon. Take care, everyone. Bye.
All right. Thanks for having me.
Bye.